Good evening, everyone. It's my pleasure tonight to introduce our keynote speaker, Ryan Moran, or Dr. Ryan Moran, Director of Washington State Healthcare Authority, or as we know it around here, HCA. Ryan brings a combination of operational leadership, public policy expertise, and a deep commitment to improving health, well-being of communities here that we serve. He currently leads one of Washington's most important public agencies, responsible for Medicaid, behavioral health services, health plan benefits for public employees and school employees, programs that touch almost 1/3 of Washingtonians. Since being selected by Governor Bob Ferguson to lead the agency, Ryan has focused in on advancing access to integrated person-centered care while strengthening partnerships across the state's healthcare ecosystem. Before coming to Washington, Ryan served as Secretary of Health, Care and Financing Medicaid Director for the Maryland Department of Health, where he oversaw a Medicaid program serving more than 1.5 million Marylanders and over 125,000 participating providers. He also served as Maryland's Acting Secretary of Health during a very critical leadership transition, and has been recognized nationally through service on the board of directors of the National Association of Medical Directors. Ryan's career also has included leadership roles in healthcare delivery system. As CEO of Whitman Walker Health System, he helped guide the nation's leading organizations to focusing on community health, healthcare equity, research, and education. Early in his career, he served in healthcare transformation leadership roles at MedStar Health, which is my alma mater too, in the Baltimore, Maryland region, where he worked to improve community health outcomes and strengthen connections between healthcare systems and communities that they serve in that region. Academically, he earned his doctorate of public health from Johns Hopkins Bloomberg School in Baltimore, where he research focused on peer recovery interventions, strategies to address opioid use and improve outcomes. He was recognized as the John Hume Scholar for his potential contributions to the field of public health and continues to bring a scholar practitioner mindset to every leadership role he assumes. I'm so glad that he's here, part of our community, just because of that factor. Lastly, on a personal note, I'm especially pleased to welcome Ryan because our professional paths share common roots. We were both shaped by the MedStar Health community out on the East Coast, in the Mid-Atlantic region, and we share many we also share an extraordinary mentor that has been committed to leadership and service and has impacted many lives. It's always rewarding to see someone carry those values on the national stage. With that said, please join me in welcoming healthcare leader, public servant, scholar, and advocate for better healthcare outcomes, and my friend, Dr. Ryan Moran.
Thanks, Ed. Thank you. Thank you. I'm gonna have to do really good after all that. How are we doing? Great. Good. I'm so excited to be here. I'm thrilled to be here, actually. So thank you so much, Ed, and for the school for the invitation. I love being back on a college campus. There's two places where my heart beats faster. It's a lecture room right here and in a hospital. That's where I sort of had my roots, got my roots. Every time I walk into a hospital facility, the heart just beats a little bit faster. But we have an interesting field that we are part of at the moment, and I just say collectively, all of us, what a time for healthcare. What a time for healthcare. And I'm gonna give you a little bit of a perspective from the state's view and the importance of the state's view on that, of where things are, particularly as it relates to the federal and state partnership that exists now at this particular moment in time. What we're focused on, or what we are thinking about from Governor Ferguson's lens about the future of healthcare and sort of the sustainability of our delivery system as we are sort of in this ecosystem of rapid change. And then also some of the just things that are in the ecosystem and in the environment to talk about. Stuff like rural health transformation, little things called HR1, opportunities of healthcare affordability, small things like program integrity. That's not a new thing, by the way. But these are really, really important things of the sort of the framing of tonight's discussion, which is coverage to care, advancing healthcare access and delivery. I think will all sort of package itself of where we find the field today. So as Ed mentioned, the Healthcare Authority, just to give you a little bit of purview for those that might not be familiar, you might be familiar, but the Healthcare Authority has three core pillars, is what we call ourselves. We have Apple Health or Medicaid. Medicaid has about almost 2 million participants here in Washington State, just under that. We also have the Public Employee and School Employee Benefits Program. So for everyone who's employed by a public, not everyone, but most of the public employees in school employee districts, a number of those organizations, we provide sort of the healthcare coverage, and the boards of those respective organizations through the Healthcare Authority approves the eligibility, also the rates for those insurers on packages for that goes out to employees as well. It's almost 700,000 individuals that are a part of that. And then the vision for Washington State with the Healthcare Authority was that the Medicaid program integrated both physical and behavioral healthcare, a model that actually was super attractive for me. In Maryland, we had a carve-out model fully of behavioral health from our managed care delivery system, and I wouldn't recommend going back to that. So that was one of the things that really, really drove me to Washington State. And so our Division of Behavioral Health Recovery, which includes all of our funding that we get from the federal government, from SAMHSA, all of our mental health block grants, all of our substance use block grants, majority of those particular funding streams come through the Healthcare Authority so that we can braid funding for behavioral health services with Medicaid. Medicaid, as we know, you may know, is the chief payer of behavioral health, both mental health and substance use services in the country. Here also that is true in Washington State. And so the idea of the Healthcare Authority was that those particular programs, non-Medicaid related, could be leveraged to drive the overall behavioral health system, with Medicaid picking up more of the pace over the course of time to be able to provide reimbursement for behavioral health services. So those are the three core functions and pillars. But as you might imagine, as Ed talked about, we touch 1/3 Washingtonians. So we like to call ourselves the biggest health plan in the state of Washington. Because in Medicaid, most of our facilitation is through what we call managed care organizations. Who works for, anybody work for an MCO? Yeah, okay, friends. Sometimes. Managed care organizations, we have 5 of those in the state of Washington. So the state, if you will, serves as the lead sort of health strategist of overseeing those facilitation of those entities and organizations. PEB and SEB, we also have a number of different plans and carriers that provide coverage to our employees there. As well. So we like to say we're the lead purchaser in the state of Washington, but also very key in driving other key focus areas of our overall healthcare delivery system on a macro level. So because you have, and the Healthcare Authority is about 25% of the state's budget on a given year, so it's pretty big. There are 2 areas. What are the 2 top areas of state spending? I'm a professor too, so I always ask questions in the classroom. What are the 2 top areas of spending? I told you one's easy. Healthcare, and what's the other one? We have to educate our kiddos. Education, right? So if you look at those two items, typically in a state, regardless of what state you are, you're more than 50%, upwards of 75%, maybe depending on where the state is, of just spending on those related items. Right, so healthcare for us here in the state of Washington, we're about 25% of the state's budget. And that gives us a lot of power. We're called the Healthcare Authority, I like to tell my team, for a reason. That means we have some authority. And in that sense, we have ways to shape the ecosystem because we're the payer of 1/3 around strategies for cost and affordability, which is sort of the limelight in the current particular environment, particularly as there's a number of related federal changes. We also play an important role in making coverage recommendations to the Washington State Legislature. I'll talk more about this, but Washington is a very, very rich package in terms of coverage. It's been heralded as a national model to be able to try to reduce the uninsured rate as much as possible, and we rank in the top 10 of states in the country to do that. We also, in the world of healthcare, and as folks try to figure out how to do more and pay a whole lot less for it, thinking about how do we align value initiatives that's focused on quality-based outcomes in care, how do we structure our contracts with our contractors and providers to be able to incentivize better care, more quality outcomes. So we have an important role to play in that particular ecosystem and space too. And then ultimately, because we serve so many Washingtonians, we have to be laser focused on who we serve, and that is the people. And so keeping customer experience and customer service at the heart of it. We may not, at the Healthcare Authority, this is what I say to my team, we may not be the ones that are on the day-to-day, like our contractors and the health plans, engaging directly with our clients to navigate them to services or care management. But we are often the front door. So our eligibility systems, when people come into the front door, those are the first introduction to the Medicaid experience, and our clients we have to hold to, and our contractors we have to hold to much high standards to be able, they're facilitating what we are deemed as the health strategists for the state. So that's a little bit about the authority. This is, since joining the Healthcare Authority under the new administration of Governor Ferguson, we've rebooted a little bit of our work. Both of our mission vision, this is actually labeled as draft because this is out for public stakeholder comment for people to be able to opine on for the direction of the future of Healthcare Authority. And it's attempts to find ourselves in the moment for the next 3-year period. Obviously a very tough fiscal climate. If you read, how many people read the Seattle Times, Washington State Standard, and the Spokane Times Review every morning? I do. Very, very helpful. If you read that, you know that the state is also in an incredibly challenging fiscal situation, getting into an even tougher fiscal situation as we approach the next legislative session. So having somewhat of a North Star, as all organizations should, as we learn in our classrooms and we know in our organizations, is really important. That is so important in a public service entity. Folks who are long-term civil servants, public servants, careerists will say it's really hard to have a strategic plan in state government. And when I first got to state government in Maryland, I said to Debbie Rupert, who had been there for 30 years as our director of eligibility of Medicaid, I said, why? When she was sort of doubting that we were going to have a strategic plan. And she said, well, that everybody else makes our priorities. The legislature passes stuff that we have to implement, makes our priorities. The federal government is a federal and state partnership with Medicaid. They make our priorities. Well, if we don't have priorities, then we're on the table for lunch, is what I told her. So having some sort of a North Star to take with our state legislator and say, this is where we actually want to take the delivery system. This is the vision of this particular administration is sort of the ultimate goal here. We have 3 focus areas in addition to our mission, which is ultimately powered by the people that we serve. That's how we introduce that particular work of creating equitable access to care, but responding to the needs of Washingtonians. At the moment, this is not a political statement, but Washingtonians or West Virginians or Marylanders, wherever you are in the state, not necessarily going to find a responsive federal government in the healthcare atmosphere. So it's really, really important that states are on the front line to be responsive to those particular needs. Second, closing gaps in health disparities and advancing health equity. It's really important, particularly as we survey sort of the cuts in funding, particularly to the most vulnerable, marginalized communities that are amongst us, that we double down on commitments to ensure that we as a state do not go back on those particular values or lose sight of those communities and ensure that they are the center of our work. And then third and foremost is strengthening agency operations. And I was at a community event where someone asked, it's very interesting that strengthening agency operations is on your overall strategic plan, because isn't that your job? You know, you run the place. It's supposed to be a strong operating place. And it's on our overall external strategic vision, because this moment in healthcare for state agencies and the Healthcare Authority is all about the basics. There's no new money on the street. There's no state accessibility for dollars to be able to provide. So if we want to keep people covered, and I'll talk about the wins of HR 1, we've got to make sure that people can access our phone systems. We got to make sure that they can get to an eligibility worker. If a provider wants to join our PEB and SEB or Medicaid network to provide behavioral health services in Walla Walla, that responsibility is on us. So we have to be sort of a well-oiled machine. It's true, state government, and it's true in Washington, can sometimes have archaic systems that are in place. And you know, I am amazed by some of the things that are tied together by bubble gum and duct tape at times. and still manage to work, or there's 4 people who haven't yet retired, but if they do, no one will know how to work that system. These are the realities. And so a lot of folks, I don't think, come to these necessarily positions thinking about that as a particular lens. They want to do transformation health policy. They want to just think up things to fall from the sky. But the moment for Washingtonians and the moment for people across the country is state agencies really need to be focused on the basics, because that's really the moment that they will receive service. I'm going to talk now, I'm going to go into HR 1. That is the biggest, because Medicaid program, 2 million Washingtonians on Medicaid, around 8 million. I'm going to share with you a little bit about the state's approach to how we are facing and addressing HR 1 provisions. HR 1 was a landmark bill, no doubt, no doubt about it. And there were a number of things in that bill. There was also a lot, because of the negotiations in Congress at the time, there's also a lot of misconceptions about the bill. And some of those we will also sort of clear up, if you will. But most notably, you have to go back, I always try, not a political statement, I have to go back when pieces of legislation are being formed at the state or federal level, and you have to think like those legislators, and you have to say, what are they trying to accomplish? What are they trying to accomplish? So if you go back to the origins of the conversations around HR 1, there are really a couple of things that really stick out. One, there was a drive of saying that there was unsustainable funding or unsustainable spending by the legislators crafting HR 1 related to the Medicaid program at the federal level, right? Two, there was this perpetuation starting to lay a foot at the ground, that there was rampant fraud, waste, and abuse in the program. That trajectory has only grown since the evolution of HR 1 being introduced, right? So, and then 3, the roots of it ultimately was to say, we need to find money from the federal government to pay for tax cuts that we are trying to pass. So the only way that you can fund tax cuts at the federal government level is you've got to find money somewhere else. Well, and the election to do that, based on the pair of sort of the unsustainable mindset of what Medicaid was and who should deserve Medicaid and the kids that are on parents' couches, we'll talk about all that in a minute, led to the idea that the expansion population, right, under the Affordable Care Act. And let's be clear, this HR 1 is not repeal and replace. It's sort of scalpel it out. That's what I call it. Scalpels out the Affordable Care Act. So they say the Affordable Care Act, how many folks know what the match rate was if states, 40 plus states, taking up expansion to provide additional coverage for a single adult 138% above poverty level. In today's calculation of money, that's $22,000 a year that you're making, right? So if you're $22,000 a year for a household of 1, and then of course it's stair steps based on your income and how many people you have in the house for other Medicaid eligibility programs. But what was the match rate that the Fed said, here states, if you implement this, this is how much you'll get? 90%. Yeah. So for every $10 that you spend on individuals, if you expand Medicaid, we'll give you $9 if you put in the other $1. Sweet deal. It was a great deal for states, right? That's why we found over the course since the Affordable Care Act was implemented, 40 plus states doing it. So one of the areas, right, where it was rich in Medicaid's population and spending that the federal government could go to these legislators to fund tax cuts was the area of 90% of that particular federal spend. And ultimately, when you put requirements like HR 1 does on making it harder for individuals to get access to care, they fall off. They don't get coverage. So therefore, that provides you the saving that's needed. Now, there are other mechanisms, right, in HR 1. We can talk about state direct payments. We could talk about 1115. That all provided this calculus, a bolus of dollars to be able to say, that's where we're finding the federal dollars to be able to fund tax cuts. And it's true. It's not a political statement. Most of the tax cuts funded disproportionately impacts wealthier statured families, right, in that regard. So that's sort of the origins of HR 1. So the federal environment, now that there is federal law that is passed, does change the trajectory of Medicaid program for states. Generally, both from the federal perspective and the state perspective. You have 4 levers in the Medicaid program for cost containment if you're looking to save money. Enrollment, so you either make it harder for people to be on, you change your eligibility requirements based on federal law. Benefits, so there are required benefits that states have to offer, then there are some optional suite of benefits that states can offer. Washington's been very generous in this regard to offering optional benefits. Rates, provider rates is your 3rd lever, and your 4th lever used to be sort of the way that states would finance their Medicaid programs through state-directed payments or provider taxes. The ability to tax or assess particular providers and to be able to draw down more federal money. H.R. 1 sort of addresses all 4 of those in terms of saving federal dollars. That is the ethos of that particular bill. So the first thing that you find, and I'm going to speed up a little bit, but the first thing that you find is, yeah, they went after eligibility for individuals on that expansion population. We'll talk about that. They are subject to increased redeterminations. If you're a Medicaid participant today, just like you enroll in an open enrollment with your employer, for those that are employed in employer-sponsored coverage, it's once every year. Now we move that to every 6 months. I'll talk why that's important in a moment. Work requirements, we'll talk about that, also known as community engagement. Future on in the years of 2028, introduction of cost sharing, so where participants are actually putting in copays for particular types of services with some restrictions. That also is in H.R. 1 for 2028. Shortening the amount of retro coverage periods. This is very, very important, wonky policy. But if I'm a Medicaid participant here in the state of Maryland, I'm here in the state of Washington, sometimes I do that. I have to remind myself I'm not in the East Coast anymore, although my suit would tell you I still am. But that was a joke. Okay. So you got it. So, but a wonky policy where if I go into a hospital, right, and I'm a Medicaid participant, I got a lot going on in my life. I have transport challenges, I've got childcare. The last thing I'm often thinking about, right, is renewing my coverage until I need a doctor, until I gotta go to the hospital, right? And so I go to the hospital and I find out, oh gosh, I didn't renew my Medicaid coverage, and that was 86 days ago. That was my renew period that I didn't miss that particular date. This is a gift, particularly for hospitals too, in this realm. Well, what you can typically do is you can say, okay, you didn't fill out your Medicaid coverage, fill out the application, and Medicaid, if you're approved, you're still eligible, retroactively take you back to the date of your end of your eligibility period. So that provider also doesn't suffer, right? So that provider also gets paid for that particular visit. You're not insured. Those windows shorten for expansion periods, right? Down to 60 days instead of that particular 90 days. Those are huge shifts. They're small, but they're tweaks that just change the trajectory and calculation of that particular funding. And then there are other provisions. I will talk about how it restricted these novel or innovative ways that states would use to fund their Medicaid programs through state-directed payments, of what that means, and provider assessment taxes. And then, who remembers staying up till 2 a.m. wondering how Senator Murkowski in the state of Alaska was going to vote? I was up. I'm just telling you. I was on my honeymoon, too. And while I'm on my honeymoon, this was a year ago, I decided, because Senator Murkowski was at the center of attention, I told my husband at the pool, I'm going to read her memoir. Far From Home came out a year ago, which is her memoir, her book. So I'm reading her memoir, and it's closing in on Will, Senator Murkowski. You know, they were up for that, 48-hour period trying to figure out if they were going to get the deal done. And my husband would ask me every few hours, okay, you're further into the book, how's she going to vote? You're further into the book, how's she going to vote? And I'd read a chapter and I'd say, she's going to vote no. And then I'd read a chapter and I'd say, she'll vote yes. She ultimately voted yes to the bill, right? She was the last holdout vote. And there were a couple of reasons that she voted yes. One, she got a lot of carve-outs for the state of Alaska for H.R. 1, for STAP recipients, for other things. The other thing that she fought really hard for in the final rounds of that particular vote was a rural health transformation fund. So there was all this concern with all the disproportional impacts of H.R. 1 impacting rural hospitals, that there would be closures of those facilities. That's very, very important for Alaska, as we know, very, very important for our state too. And so she ultimately voted yes, she'll move the bill forward. And there was one of the misconceptions of HR 1 is that one of the reasons that it passed was because it was going to provide a safety net of dollars for rural hospitals in advance of HR 1's cuts. But the reality is, one of the misconceptions is because there was so much happening, one, it's not just for hospitals. We'll talk about the state's approach there. And number two, it can't be used for direct services. So it's not like the Healthcare Authority is the lead applicant for Washington on the state's $181 million award, which we received, can just stroke a check for somebody in Asotin County, right? Or someone or Confluence in Wenatchee. We're not able to do that. So there are certain initiatives that are transformation in nature that we have to follow to be able to fund those things. And we'll talk about that a little bit. Okay, so those are the big sort of outlines. Our approach here in Washington, all about Washingtonian. All about the Washingtonian. Significant changes in eligibility rules. We've got a couple of principles. We come back to these almost daily in our design sessions and discussions with stakeholders and policy folks and our governor's office to figure out how are we navigating this first. One, we're trying to make this the least burdensome on the client, continue their coverage, trying to make it as administratively efficient as possible. We're trying to ensure that we're partnering with all different types of stakeholders, because the reality is we'll need everybody's sort of best idea to figure out how do we implement this particular work. We at the state agency don't have all the answers. We're fooling ourselves if we do. So we're trying to take a very deliberate approach. Partner organizations, other state agencies, providers, our 29 federally recognized tribes, and our 2 urban health Indian programs here in the state, and so many others. Here's a compliance timeline. I'm not going to go through this in detail, but you can see the enormity of each one of these particular changes, and just think about sort of the lift that the states have in a very short period of time to be able to implement all this particular type of work. I'm going to walk through a couple of these from the compliance timeline and focus on them. The first one is, again, a way to contain costs or a way to reduce costs to fund tax cuts back to HR 1. What's to change enrollment? One of the changes makes changes on the definition of lawfully present non-US citizens. So these are individuals who are here with lawfully present status. We're not talking about undocumented individuals. We're talking about lawfully present folks. There are about 14,000 individuals who live in the state of Washington that because of this change in particular status, these as examples are refugees, they are victims of human trafficking. Again, there are about 14,000 of those folks across the state of Washington. And then we received, so the other thing is we're moving very quickly. So we've received guidance, from our federal partner. The hallmark of the Medicaid program is it's not just the states, it's the feds too. The feds and the states do this little dance where they're our regulator, we're the implementer. We have to make sure that we're compliant with federal law, but then the state legislature gets to say what we can pass, but the feds have to approve it. So we all just do a little dance together. And it's very important that we get clear rules from the federal government, not only because we want to know how to implement it, but 2, we want to be able to follow the rules. Because if states don't follow the rules, you're out of line with federal law. So, and your federal regulator can go after you in that sense. Some of the other changes on provisions. This is the one that gets the most limelight. Work requirements or community engagement is what the administration calls about it. Individuals, all the 600,000 individuals in Washington that got coverage under the Affordable Care Act, those adults primarily, will be subject to this particular provision in January. And this month was a pretty significant month because we just got the rules that showed us how to implement this particular policy. That is, I cannot stress to you how incredibly challenging that is. We've been working over the last year on verbal guidance from the federal government. There's nothing but meetings, dribs and drabs of saying, here's what's coming, here's sort of the structure that you should move about. But finally in writing on the first, which was their statutory requirement, this rule was released that gave states a blueprint, a pathway to think about implementation. Let's talk about work requirements and what that means for the 600,000 Washingtonians that have to go through this process. So one of the things about work requirements is a lot of people think that, oh gosh, now you have to like get an employer letter, or like how will you do that? Well, one of the things about Medicaid eligibility that the state is trying to do is to automate this as much as possible. So we have, at the state of Washington, we have access to individuals' income data through various data sources that we have, right? Through the Employment Security Department at the state of Washington. So we can tell, or we have access to individuals where they meet these particular thresholds of having income, which shows that you're working at least 80 hours times the federal minimum wage of $7.25, but in Washington we have a more generous minimum wage, so that's actually helpful for individuals here in the state. And so just by this particular provision alone, individuals will actually have to do nothing to renew their coverage with the state of Washington, because we already have access to income information. About a third, a little bit more than a third of those individuals, we are able to automate coverage right off the bat. Don't even have to send them a piece of paper. They don't do nothing to prove work requirements because we have income. Then there are these other things that talks about what are some of the exemptions that the law lays out. They did lay out some exemptions that people don't have to go through work requirements. If you're under 18, if you're a foster youth, if you're pregnant, if you're a parent caretaker, if you're a tribal member, American Indian Alaska Native, these are all exemptions where you don't have to sort of meet any type of work requirement, particular provision. Well, we also have claims and demographic and a whole other host of data access at the state level of some of this information. And so if you take a look at this particular list of all of the things, we have taken a look at that and we say, okay, that pushes us a little bit more over about half to 60% of individuals on this list we think we would be able to renew their coverage automatically. The state has built currently today, we've built what we call a verification hub, where basically we look across the state, we have information and data on people through multiple different state agencies, and we say, where can we find information on people and automate their coverage? Anybody have a guess of how much it takes us to implement HR 1 and that verification hub and all the people that we need to be able to ensure that we have staff for it? How much money? $4 billion. Good sure. Yeah, so in year one, just of year one of implementation, the legislature passed for the agency and our sister agencies to implement this work of $165 million. $165 million. So $165 million of taxpayer dollars to build computer systems, right, and verification hubs that ultimately do what? We provide less services, right? We're trying to retain people, right, to be able to stay on coverage, but ultimately we'll not be able to catch everybody through these particular requirements. So it's a very interesting equation. I say the only people who win from HR 1 passing are information technology companies. And so the other thing I would note here too is there's one that you hear a lot about currently in the media, and that is this exemption around medically frail. So all these other things, right, they're very much demographic. We find this information. And states, for the past year, we've been receiving verbal guidance from the federal government to say individuals can receive an exemption for work requirements if you're medically frail, and it'll be okay if you use a diagnosis to be able to come to that determination. So that means like, okay, I'm Ryan, I have cancer, or I have COPD, or I have end-stage renal disease. The state has access to my Medicaid claims information because I'm already a Medicaid participant. Our verification hub that I talked about, we've built that so that we can pull the claims information in and say, you're automatically enrolled because we're going to deem you have a condition that's medically frail that likely impairs your ability to work. All states were like, great. That is like a way that we can do that. We can automate that. Dr. Oz, we meet with him regularly. He says, I want to digitize this whole process. Great. That's digitizing the whole process. The rule, unfortunately, takes a pretty big deviation from that. right, for us as states, which it says, guess what? Your cancer diagnosis is not enough to prove that you're medically frail, or your COPD or your end-stage renal disease is not necessarily enough to prove that you're medically frail. You have to have some other type of way to prove that that diagnosis impairs someone's inability to work. How do you do that? What are some of the guidelines, right, that states were given to be able to figure out, like, diagnosis plus ability to work? There were none. The rule was silent on those things, right? If you're a physician, any clinicians in the room? Any clinicians in the room? There's a specialty that does that, physical medicine, right, and rehabilitation. They do sort of like those workups of individuals' capability to work. But primary care workforce isn't necessarily determined. Sure, they can give you a sick note to say, like, yeah, you probably shouldn't go to work. But are they there to be that analysis? And then you run down rabbit holes. I was just on a phone with the state senator from Southwest Washington this morning, Republican. Don't care about what letter's behind your name, but context is important. And he was saying, well, that might be the intent of the law, right? We want people to work. We want people to be part of their community. And just because you're sick may not mean you're not able to work. And I said, yeah, but let me give you an example. If I'm somebody who works in the mining industry or manufacturing, right, and I've got a diagnosis of COPD or cancer or whatever, end-stage renal disease, that really might impair my ability to actually do that manufacturing or mining job. But does that necessarily impair me to do like a desk job? Maybe not. But I'm trained as a miner and a manufacturer. So how do you figure out how to navigate people? Like, how do you actually prove that someone is not? And he was like, oh yeah, great point. Because he's got a lot of manufacturing folks who work in his particular district. So that particular example lets people say, oh, that would be hard to implement. So by the end of the conversation, sort of some clarity around that. So, this is up for the states to figure out. That's the whole point, is just try to figure out how we navigate some of those changes for folks. 6-month redeterminations. This is, I was at a conference last week at the American Association of Health Administration conference with Jeff, who happened to be in the audience. And this is actually one of the most, community engagement work requirements gets a lot of talk, but I'm most concerned or have a lot of concerns about 6-month redeterminations. People have to apply every 6 months. We know across the country, if you look at Medicaid programs, we've been fortunate in Washington that individuals be able or apply and renew their coverage because we're able to automatic enrollment at a very high rate. But we know that for individuals that fall through the cracks on that paper process, who we're not able to enroll or automate, right now, for when they have to renew their coverage once a year, about 25 to a third of those individuals, the data says, fall off their coverage because they just simply forgot to enroll. And then, the ability, we were helped by retroactive periods so that they can come back onto particular coverage. But if you can imagine a situation where people have to do that twice a year, I'm glad I don't have to do my employer-sponsored coverage of enroll that twice a year. Just how taxing that is, and then when the retro periods are even shorter. So you see the chip and chip and chip and chip and chip away of coverage pathways for people to do. That's really the eligibility provisions in summary. There's a ton in the bill about state-directed payments and provider taxes. These are financing mechanisms where we're able to use avenues to pull down more federal dollars from the provision of federal funds to be able to provide more sufficient rates in our Medicaid programs for certain providers. In the state of Washington, there was changes in H.R. 1 that capped the ability for state direct payments to be used and also changed the rules around taxes. Without getting into the weeds, all of that, essentially when all said and done over the next few years, they will go down over a period of time, the ability to be able to draw down more federal funding for that. But about $1.5 billion will be lost in Washington's system just on hospital reimbursements alone. And our team is still trying to work on this because the final rule of these state-directed payments from the federal government were released a couple of weeks ago. But they went even further to put caps on other type of services as well. So we're sort of assessing, in addition to Washington's SNAP program, we call it the Safety Net Assistance Program here. It's been a hallmark of funding for hospitals here in the state of Washington to be able to use. In addition to that, what are some of the other impacts related to federal funding? Customer outreach, we are doing everything that we can. We have community assister, community navigator programs. The best work is community-oriented, community-led, community-based. And so we know that the state isn't necessarily the best messenger, but leveraging community health workers, providers, where folks go to receive care, connecting with individuals, trying to rally around the community about the guidance that we have and what people are supposed to do. And outreach is going to ramp up very quickly for us. We've obviously been out and about talking about sort of the changes, how people can prepare, making sure their contact information is up to date so we can reach them when it's their time for particular changes. But this just gives you a sense of what's happening over the next 6 months. And then the Lisa Murkowski provision, I'll just the Rural Health Transformation Program. But this is, I grew up in coal country, West Virginia. I grew up in a town of 84 people, 83 I left. And this is super, super personal for me. I grew up on a beef cattle farm. My grandmother, who is my best friend, Granny Colleen May Riggleman, ran. The only place she wanted to die was in our critical access 25-bed hospital, and I held her as she died there. So the work of rural healthcare is just an incredible. And so I'm so happy to come to the state of Washington. I was just telling Catherine too, I met with Senator Mazzol for the first time a year ago, who represents Whidbey Island, who's a farmer here in Washington. And I walked into his office, he's got a vest on and a bolo tie. And I'm like, oh my gosh, I'm talking to Uncle Dave. I'm talking to Uncle Dave. It was Uncle Dave, Uncle Dave. But this stuff really matters to me on a very personal level. HCA is entrusted to be the lead in navigating this particular work. We were successful in receiving $181 million a year for a 5-year period to invest in rural health communities. Again, while it can't be used for direct services, there are very rigid funding criterias. These are our high-level areas of focus on workforce, a focus on technology, a focus on updating our rural hospital infrastructure and our behavioral health system, and I'm happy to share more about some ideas in that. We are moving very fast. Also, this states with their one year award period, $181 million, has to obligate all of that. We received the award on December the 30th. We have to obligate all that money to partners by the end of September. They have an additional year to spend that. That is very, very fast to get $181 million out the door from the state's perspective, particularly when you have to get legislative authorization, which we were able to do. Then you have to move through contracting and procurement policies in state government. Surprise, not fast. So there's very big challenges for states to be able to do. We're fortunate in Washington. Yesterday, received a briefing where more than half of our $181 million has already been obligated to partner organizations. And we have a lot more money that will be going out the door through competitive RFP processes over the next 60 days. So looking forward to very much for that. The last two subjects I want to, and I hope I'm not too over, but I will just touch on briefly. But from the healthcare authority's perspective, we play an important role in healthcare affordability. And looking at healthcare affordability, there are a couple of different avenues and groups that we have that helps us do that, to look at our ecosystem. The legislature entrusts our agency with a couple of different boards. Prescription Drug Affordability Board, which is assessing the cost of unaffordable prescription drugs. We are assessing 2 particular drugs right now that will be able to cap sort of pricing that is spending and sort of wide ability to be able to cap those particular prices on consumers. We're learning from other states who have gone before us, Colorado, Maryland, others that have prescription drug affordabilities. We gain sort of new regulatory authority to be able to navigate and cap the costs of certain particular drugs in 2027. That's when the legislative authority for us kicks in. So we have a team that's doing that. We also have a cost transparency board, which is to look, their charge is to look at sort of the overall aggregate picture of the healthcare spending and try to ensure that we're capping cost growth within the spending. For this particular year, they are looking at ensuring that they are, what's the role of mergers and consolidations within the particular market, not just from a hospital and health system perspective, right, where all the independent practices, right, in order to be able to survive, or people retirement, large health systems purchase those organizations and they merge and acquire those. What is the impact of overall healthcare spending in those transactions? Should the state, should someone play a little bit more role in reviewing that particular work? What's that particular impact? Would that provide value? Those types of questions. To improve the primary care spend, so to change the cost curve of more acute spending to primary care, the ability is to say, let's try to sort of change that particular cost curve. What are ways for able to do that? So that's the current work of the cost board. Some of the other work that has happened that the cost board has looked at and recommended to the legislature, we have no authority, right? We have to make recommendations to the legislature and then the legislature has to act. So I'll just make that very, very clear. This is an open public meeting. Folks come, provide comment, provide their thoughts, perspective. We hear from lots of different stakeholders along the way, but everything goes to the legislature. One of those that went to the legislature, not this past year, but 2025, prior to my arrival, was looking at reference pricing in our public employee and school employee benefits. Essentially what that means is as a benefit program for employee and public employees, looking at where Medicare sets their particular rates, not just for hospitals, which is what gets talked about the most, but also increasing the rates for primary care and behavioral health care services, but also because acute care spending is one of the largest portions of spending in our healthcare delivery system, looking at capping the costs of hospital expenditures. What does that do for the overall market as well? And the last thing I want to just touch on in this environment is program integrity, fraud, waste, and abuse. How many people have read fraud, waste, and abuse stuff in the last year? It's like fraud, waste, and abuse. Fraud. When I was Medicaid director in Maryland, I was at this really small community listening session in Allegheny County, and someone stood up in the back of the room. This was before the Trump administration 2. Someone stood up and said, Deputy Secretary Moran, do you have fraud in your Medicaid program? Very serious. Like I'm, in sort of a rural area in Maryland. And I'm like, of course I do. And I think the guy was shocked. It's like, yes, I do. You cannot run a $25 billion agency enterprise and expect there to be good actors everywhere. If you have humans, you have bad actors. That's just the reality of what it is, because people will try to figure out what the particular system. Of course I have fraud in my system. And you're asking me the wrong question. The right question is, what are you doing, or how can states be able to support the detection, prevention of fraud? Do you have all different avenues for people to be able to report? Do you have the analytical tools to say that provider is billing incorrectly or that provider is billing fraudulently? And in fact, those aren't the same thing. So that's also an important point at the moment, right? Where fraud, waste, and corruption are all the things being blended together. We gotta be really careful about that. Fraud is the intentional deception on the system. Waste and abuse, right, is things that we need to work on in terms of efficiency in our healthcare system, but is not necessarily intentional deception. So we have to be very careful about our particular terms that we're using. But states, at the moment, the Trump administration is focused on fraud. And fraud is not a new subject for states. Every state has a Medicaid fraud and control unit that when things are reported, states have staff, we look into issues, or we have tools, we have technology systems that look into issues, and then we refer it to our attorney generals to do investigations. We prosecute individuals. We take back money for those particular things. We have certain tools that be able to do that. There are certain federal requirements in this particular regard. And where states really need support is bolstering those particular tools. But remember what I said at the beginning, this is a federal and this is a state partnership. The federal and the state have to be in partnership together on this, not the federal government or the state being adversarial based on, we're gonna punish you based on sort of what happens related to your areas. So at the moment, here in the state of Washington, what's that all mean? What does this all mean when Dr. Oz or other people are talking about fraud? Well, they're really focused on a few key areas. I will tell you, healthcare is so regulated, as we all know, but the healthcare authority from the federal government and the programs that we oversee are so regulated already. The amount of reports, the amount of things that we have to submit is insanity, right? The sort of the amount of work that goes into sort of public transparency, public accountability for all these particular reports. On top of all that, we've been subject to a number of different audits or reviews, either from US Congress or from CMS explicitly. What are they looking for? If they think fraud, waste, and abuse in the system, let me give you some examples. One of the things they're looking for is making sure that high-risk providers, which is outlined in federal statute as home health, hospice, and durable medical equipment providers, those are individuals who have been deemed long time in federal statute as individuals who are high risk, touch vulnerable clients, ensuring that they are validated and enrolled proper ways, right? You're doing security checks, making sure you got background information on those things. Just think of it as like an employment screen. There's on-site provisions, making sure you're assessing the quality of those particular providers, right, in that realm. So we in Washington feel very good about our ability and our work in ensuring that high-risk providers are properly monitored and revalidated within our system. But they want to make sure that all other states are looking for that. State of Minnesota currently is subject to about $240 million per quarter of their federal funds being withheld because of CMS's concerns with their sort of overview and monitoring of high-risk providers. So that's a reality. I haven't got one of those letters yet. Happy about that. Yeah, right. And at some point, too, the other areas that they're focusing on is citizenship, eligibility within Medicare, right? A hallmark, you gotta remember why things happen. Hallmark political issue of this administration is undocumented individuals. We're seeing this with ICE, deportation. We're also seeing this with what they passed in H.R. 1, changing statuses on Medicaid eligibility. They're laser focused on undocumented individuals, making sure that they are appropriately spending. In Medicaid, individuals who are undocumented, today there are certain thresholds, right? One of those thresholds in terms of being able to receive Medicaid services is for emergency medical care. So if you're undocumented and you receive emergency medical care, it's a key way, right, for individuals, they don't have any access to go anywhere, come to the facility. It's been longstanding federal statute, individuals able to provide undocumented medical coverage, right? We have that in Maryland, it's federal. We have that in Washington, it's federal law. Who has a guess of on a quarter, what the state of Washington spends on Medicaid coverage for undocumented individuals for emergency care? What is it? $20 million. $20 million a quarter, right? Just on emergency services. So what does CMS do? They send me a list of 20,000 lines on an Excel spreadsheet. And they say, Ryan, go verify that all of these particular claims, because we share data with the federal government, it's the hallmark partnership between the feds and the state, go validate that all these individuals appropriately were enrolled in the Medicaid program just for emergency services. So there's very certain things in emergency services that you can cover and under very certain time periods, right? So you can't cover things for the long term. So so they send this, they send one Excel spreadsheet, 20,000 per month. There's often duplicates. You have to say, well, these are duplicates, sorry. How you want us to do this. First 2 quarters, right? So around $45 million. What do you think the number was that we determined in the state of Washington that we were inappropriately paying for emergency Medicaid services for undocumented individuals? $40,000. That's it. Yeah. After a rigorous federal review, rigorous state review.
How much was that staff?
Thank you. You get an A in my class. I spent more taxpayer dollars on evaluating, right, this whole list of 20,000 people on a spreadsheet than I actually did and the individuals, right, or the claims that we found that were inappropriate that made up this 40,000 and over the 40 to 45 million dollars weren't because necessarily individuals were receiving, we got it wrong. It's because we couldn't find the piece of paperwork to prove it, right? And so you have to improve your systems to be able to do that, right? They're all hosts of source of reasons. These are the things that the state is up against. In addition to implementing HR 1 and all that, right? We're doing these particular reviews. You will get a ton of support from me for program integrity. You're a bad actor in my program, you're out. You're out. I got no tolerance for it, right? But I believe fully that most folks who are working in our spaces, in the PEB and SEB program and in the Medicaid program, are trustworthy, hardworking folks who want to do the right thing. Is that the case 100% of the time? You betcha it's not. I ain't foolish. But we know that this is sort of like what the state is up against. Fortunately, Washington has very, very strong protocols in terms of its fraud, waste, and abuse oversights. I've been extremely pressed since coming here about a year ago about what we have in this particular space, and hope every morning when I wake up that we don't get a letter like that. And so you should be proud at the moment. And even if you do wake up and see a letter on the Seattle Times, ask really tough questions about what actually happened and what else might be happening. My grandmother would say, paper lays still. Anybody can write anything on paper. So it's very important to sort of discern. And this field, right, our field should be able to discern those questions. It's been a gift to be able to be with all of you. I'm happy to take any questions now. I think Catherine's going to lead us into a little bit of session if I've left any time.
I wanted to get the ball rolling. I had a question for you. I have a brother who has a developmental disability, and he actually works. He's on Medicaid, but he has a job. He doesn't work 20 hours a week. And I was wondering, when I was looking through your list of folks who have a like an eligibility requirement to work, I didn't see people with disabilities, not necessarily just developmental, but maybe physical disabilities might prevent them from working. So what is their situation under the new bill?
So remember, we go back to the different, and this is also another misconception about the work and about HR 1, and I'll clear this up in a minute too. But Medicaid is driven by eligibility categories, functionally at their name. So you can qualify for Medicaid just based on the nature and realm of income, right? Which is where generally most of the individuals who are receiving your expansion population, very geared towards income-related type of eligibility. There are other eligibility pathways for individuals who are age blind, disabled, we call that ABD categories within the program, who receive Medicaid coverage under certain circumstances, right? So those individuals, those particular programs, are not necessarily subject to the HR 1 provisions that you find here for the expansion populations. However, some individuals, right, in these expansion populations, based on those particular exemptions criteria of being medically frail, people who meet some criteria within managed care organizations for long-term services and supports, where you get into sort of more of those particular elements, would fall within these particular categories. And that is why states wanted to rely on sort of the ability of diagnosis codes and those to be able to exempt those individuals who would fall within that eligibility criteria. One of the criteria that's listed in the medical frailty, sort of individuals with complex medical needs, right? So where potentially individuals who, if there were, would fall within that particular category. So, but let's not kid ourselves, right? Which is what I always say. One cut to the Medicaid program is a cut to the whole Medicaid program. So just because you're going after eligibility enrollment for this particular group puts strain and pressure, and then the other cuts that happens with the state-directed payments put strain and pressures on your other parts and budgets of the Medicaid programs. So for individuals, and Washington has been a leader in the home community-based services space and the developmental disabilities space, for Medicaid coverage in this regard, right? As we get pinched by other federal cuts and federal strains, you have to look and say, where else, particularly as if the state is in a tough state fiscal situation, where else in the program do you go for cost containment in that realm? And so that's where we get into those particular issues. So while you may, right, fall within a category, right, for individuals who are pregnant, fall within a particular category where you're not necessarily subject to these particular provisions, on the whole, states are having to make decisions to figure out how to fund their entirety of their Medicaid program, and it could impact folks.
The floor is open for questions. There should be a mic on your table, and please use the mic. We're being recorded, and we'd like to make sure that people watching the recording can hear your question. And just raise your hand and I'll call on you. Yes, in the back, please.
What are you projecting you're going to lose out of that 2 million of Medicaid members once all this goes into effect?
Yeah, our initial projections about a year ago were around somewhere between 200,000 to 250,000 individuals. That is smart analytical work to be able to come up with those projections. And and we were actually just talking about this today. There were some other changes that happened based on these particular rules that we at the states necessarily weren't accounting for. That likely will cause more losses in healthcare coverage than we originally anticipated. You know, the fact that we won't be able to use just apparently as of today, just diagnosis codes to exempt people from medical frailty means that those individuals, who we were going to capture through an automated, digitized way, are going to fall through the cracks. Other instances are, things that are very complicated as part of the law, but Washington and 36 other states is a 1634 state, which means that if you qualify for SSI disability coverage, then you automatically cover for Medicaid coverage. And there's a conflict between the two statutes of H.R. 1 and the underlying Social Security statute. And so we're wrestling as a state to figure out what's the conflict, how do we clear that up? H.R. 1 says that individuals who are these non-citizens can't be covered, or individuals who are these lawfully present citizens who are going to be losing coverage in October can't be covered. But then the SSA says, well, you're deemed eligible if you have SSI, and some of these individuals do have SSI. So there are things like that keep coming up that once you get into these policy details and weeds of this really matter and potentially could make those original estimates increase.
Hello? Yes.
Perfectly placed.
Yeah.
Oh, it's good.
Firstly, thank you so much for sharing insight into some of the technicalities and how HCA is responding to HR 1. Listening to this, a group of leaders and emergent leaders have a very physiological response to an emotional response to how this is constricting and restricting our populations that we're invested into trying to create health equity. And I'm curious, as a leader yourself in this area, how are you reconciling with these realities and not getting overwhelmed by discouragement?
Daily practice. Seriously, it's really hard, right? It's really, really hard. I started in this work, as I said, I grew up in rural West Virginia. We lost access to coverage. I remember my dad coming home and saying, how are we going to find our kids' healthcare coverage to my mom? And I was going to go into meteorology at the time, predict the weather. That would have been a fun job in Washington. That image of him doing that, we were having green beans, I remember that evening, is just ingrained into my body of I've got to get out of the weather business or weather dreaming and get on the front lines of making sure that families and kids don't go through this situation again, because it was just an agonizing situation I could see for my folks. That's what really drives me. So life mission of trying, probably sounds like you, removing every single barrier that stands in the way for people to access care. Every day I wake up and I say, I cannot, and I think there are a lot of people, I meet stakeholders every day, hospital association, home care associations, community health centers, everyone is just in a state of, oh my gosh, what are we gonna do to be able to provide and serve our communities? And I call it, the way that I've tried to reconcile it, even for myself, is everyone's on their different stage of their grief journey on all of this from a year ago. And I have had to, every day I sort of wake up and say, I gotta be in the acceptance part of the grief journey for me to be able to be on the front line, to be able to protect people. And one of the things that I tell our team and our staff, because we employ individuals who are most amazing public servants I've ever met, who built these programs, started the Affordable Care Act here in the state of Washington from scratch, and are now seeing it all go down. And the mission doesn't really change. The mission hasn't really changed for me, even though it's not in a way that I would want it. The mission just is, I've got to do everything that I can to protect people based on the tools and the resources that I do have. I do think that this is very strategic of the legislation and the lawmakers to write this in a way that sort of gets implemented after the midterm elections. So that's another thing, right? Even the final rules gives certain provisions of what states can communicate and how states can communicate on how this works, to be able to very strategically get into the political realm of who to blame and who not to blame. But I just get up every day and I say, what can I do to try to keep removing barriers even in this moment? The other thing too is there's this is the last thing I'll say, there's this perspective that, because we're not in power, or because we've lost power, however you want to describe that for yourself, is that we have none. We actually have a lot of it. We still have a lot of it. And we have to remind ourselves of the power that we do have every single day to make a difference for people. And I'm really glad, right, to live in Washington State. I'm really glad to be in a state and to work for a governor who is on the front lines, committed wholeheartedly to this particular work. What you heard from me this evening does not happen, if you will, in some other states across the country of trying to figure this out in the same way. And we do it with community together. Figure it out. Yeah. One month. Yeah.
Thank you. Thanks for the talk. It was a great overview. I also love the fact you have a rural community background and bringing that forth. And I want to go on to that a little bit and ask you a little bit more about the Rural Health Transformation Program and what your thoughts are on that program and projections of what you think the possible impact could be of that in the state. And if the state has any thoughts on actual goals or metrics that they want to achieve through that program.
Yeah, good question. So it's as I mentioned, the total overall pot of funding is about $181 million. We have sort of 6 areas of priority focus. We have tried to facilitate, we've been pretty in tune to this. One of the biggest worries I think states have about their overall rural health transformations, any shade of the Crayola color, is it creates a fiscal cliff after 5 years. So we want to try to steer investments that can be a bit sustainable in that regard of long-lasting impact, where we're just not giving somebody money to run a program and then the money goes away and then the program goes away with it. So as examples of that, and because you can't use it for direct services, the Rural Collaborative, representing 30 plus rural hospitals in the state, is leveraging its dollars to try to improve revenue cycle functions, as an example, for hospitals and rural facilities, to be able to try to get more collections from payers and to advance their tools in that particular regard. We think that those are sort of sustainable updates in technology that allows them sort of to keep going for the long run. And so a lot of the metrics in those 6 areas try to get to that long-term sustainability question. In terms of, I do think it does have an impact. You cannot be any money, it's the only money currently right now on the street. It is not, there is no way, right, that the dollars that are going to be giving out in any way, shape, or form is disproportional to the overall cuts that are further coming, which makes it very challenging. But for a hospital that hasn't had a boiler system updated since the war times, or a hospital who doesn't have particular tools that they need for revenue cycle or technology, it's a huge deal for those particular investments. And so we at the state are trying to make sure that those huge deals happen so that people can be on strong footing to be able to weather the storm for them that's coming next. And the other thing I will say about that is it's one application for one time. So the states, everybody went about an application, you submitted it for 1 year, for a 5-year period. You don't have to necessarily go through the application period, but the federal government can change its funding calculation to states from year to year. So and one of the reasons there was a lot of assessment, a lot of analysis of like, did Washington get enough money, right? If you look at the per capita amount of money that Lisa Murkowski in Alaska got, it's very different than the per capita amount in the state of Washington. A lot of states made choices in their application. You ranked higher in your score as states if you aligned with policy commitments to the current administration. So I'll give you an example. If you were a state who said, I will introduce no soda pop in SNAP waivers, as an example, then you got a better score in terms of your particular calculation of that. We did not necessarily, as a state, make those particular type of commitments that align with the current federal administration, because number one, you have to get those commitments through your state legislature, right? An idea that I just mentioned is not likely to get through the state legislature in Washington. So we think from where we sit that there are going to be a lot of states who may not be able to live up with those future policy commitments, and that could change the funding calculation. So we're hoping in year 2 or year 3 or year 4 or year 5, we actually get more dollars than the 181, which is a very possibility, but we'll see. And you have to spend it. So if states don't spend it, it's gone. So that's why, our rush to obligate that spending by October. One of the background worries I have is we're moving so fast to answer your long-term question, to get this money out the door, to make sure that it's sustainable. We're trying to make the right choices. We're doing everything that we can in the frameworks that we have to do that. And are we moving so fast that we will look back sort of and say, did we miss something? We probably missed something. I do worry about that.
Other questions? Yes.
Thank you so much again for tonight's
Community Health Plan of Washington. I see the logo.
Oh, yes, Community Health Plan. Yeah. So I think one of the concerns that we hear from community, right, I think, and I speak to a lot of the community, but a lot for immigrants and refugees, is focused on health information and data privacy. And I know that came up as a concern a couple months ago, and I think all of us are trying to make kind of sense of it. So I'm trying to figure out, as leading the healthcare authority, have you kind of navigated those conversations to try to rebuild trust with the community in terms of I think it's kind of hard with data privacy. I think a couple of years ago we could have said everything in HIPAA is protected now, things have kind of changed. But how do you kind of navigate those challenging waters?
It's really challenging too. Couple of things I'd say about that is, again, back to it's a hallmark partnership of the federal and state government, right? So, state Medicaid program facilitates the program on behalf of you. We historically, right across the country since the inception of Medicaid, have shared data of individuals and customers for facilitation. So you can make sure that we're doing what you need to do or you need to audit us. We share that data through a system we call TAMSIS, right, which is where individuals, this information goes. I'm not sure that we have the appropriate solutions right now, particularly for immigrant communities around data sharing at the moment. The situation is just too volatile related to the activities of ICE. We don't have much, there have been a lot of conversations, right, at this particular juncture. We don't have, other than litigation and activities that's been taking place within the courts of attempts to try to thwart or delay or withhold, stop, temporarily name the strategy. We don't have a whole lot of levers to be able to use for ourselves. The one unfortunate thing is, for all of us working in this space, including immigration advocates, we worked for years on this won't be subject to public charge, this won't be subject to public charge, your data won't be used, to try to ingrain that within community, and just the the devastation now in the world now of that not being a promise that was a promise made and promise kept for this particular realm. We got other challenges afoot with other communities in focus of this particular administration. There are 2 rules that we expect to be finalized pretty soon on gender-affirming care. One, prohibiting Medicaid spender for gender-affirming care for youth, and then 2, prohibiting any hospitals from receiving any type of Medicare or Medicaid funding if they are providing gender-affirming care too. We, of course, for any Medicaid participant, share information related to those types of service as well. So I live in a place called Hope because I have to answer your question. And I do think the world we're not going to stay here forever. I live in that place that I'm not going to stay here forever. We're not going to stay here forever. So I keep going. So that reminds me that we won't be here forever. And I think where the solutions are going to come is in a couple of years for all of this, because there's this tendency for us to say let's just go back to the way that it was. Pick the thing, data sharing, trust with community, fraud, waste, and abuse, whatever. Let's just go back to sort of how. I don't think we can go back. I think we're going to have some really serious conversations about what it all looks like to get community trust back. How do we envision new laws, new safeguards at the federal level if there is changes in political power, both for all 3 branches, how we try to sort of shore up some of these things for the future. If there's one, thing about this particular moment, it's kind of showed us where the holes are, both from democracy to data sharing. And, I think it's up to us to go to where those lights are in those holes and work to bust through and keep being light for future.
I think we have time for one more question.
Yeah, Ed.
Maybe I have a 2-part. In terms of HR1, a lot of people, the public, we understand the impact it's going to have in terms of healthcare access and individuals. What's not really talked about is from the healthcare delivery side that's money being taken out of the system. And the question, it's a 2-part question. One question is, have we factored in how many people will lose access to healthcare because hospitals, especially critical access areas, hospitals will no longer be able to exist? And secondly, to a group of people who are going off into the workforce here to help improve access and lower healthcare, what's the call to action for us to help you create more access, save our hospitals, and make care better in Washington?
Yeah, I don't know if I have a perfect answer on the totality of the impacts of the delivery system. The market is gonna, in ways that we have levers, we're trying to control a little bit of some of those dynamics. I'm particularly worried in the Medicaid program, as organizations of all types and providers try to think about their own sustainability and their own payer mix. How do you try to preserve Medicaid access in that realm? And so thinking about future solutions for that in upcoming session and other ideas of what are some of the things we can still encourage access as we start to see some dwindling of potential resources. I think that the call to action in this particular moment in time for us as a state is we cannot do this alone, so we need everybody in this room and all your organizations. I said at an event, I think some folks in the back were there at the State of Reform event, one of the things that I said was, because you don't have a responsive federal government, right? I gave the example of the rule, right, about the work requirements rule. They wrote a rule that said you can't use diagnosis codes and has to prove your ability to work. How do you do that? That isn't being responsive to try to figure people out. That just seems to me just another rabbit hole for people to lose coverage. But for us, it's okay, we're now on the front lines of this as a state. And when people come to us, because people right now, I think the most, and this goes back to your question, people are most hungry for is like certainty, like what's the answer, you know, what am I supposed to do, what am I supposed to tell people? And there's been a lot of times over the past year where we've had to tell the hospital association or others, whoever it might be who comes, participants, and say, we don't know what the answer is. Or we will have to like invite you into a conversation of like, what's your idea? If you were us, what would you do? Or if you had an idea like of how to make that operationalized, how would you do that in your organization? And we're having those conversations. But the I don't know from the state side of what you might get from a state servant like me isn't incompetence of like, that's just bureaucracy, government incompetence, people don't know what they're doing, public servants, sort of the typical stereotypes. That's actually true, we don't know. So we do need the field to help us to know, because we're gonna kind of need all of us. I think there was a world without the Affordable Care Act. Unfortunately, there was. And if you look at some of the things that states did to try to shore up its delivery system prior to the Affordable Care Act, for a period in time, I think we're going to have to go back to those things. The unfortunate part about that is that burden of going back to those models, whether it's, you know, we'll provide more, we'll sort of target funding to the safety net of the particular system, or, you know, we'll have limited benefit packages of offering people not maybe the full scope of healthcare coverage, but maybe some primary care, some behavioral health, and some pharmacy care, or whatever that might be. Like those models existed before the Affordable Care Act, but the challenging part, as we all see here in the state of Washington, the confluence of the federal government, the changing and economic climate that we have, as we all see at our gas pumps, the changing inflation of continued population growth just has put an incredible amount of strain on the state budget, that it's going to be hard. It's going to be hard for states for Washington to say, how do we kind of like go back to those particular models of finding funding and sources to be able to support the safety net. So, but I think the call to action is we need you. Got to help us. We can't be everywhere in the state. You got to help us figure out how to get this information to clients once we have it. And if we need your ideas, and if you were in our shoes, like what would you do? What would you do? And we need those ideas.
Right. Thank you so much.
Yeah. Thanks.